So, good morning, Penny and Mel. Thank you for your time today. So, I have three questions for you. Let's get started. Um, so, I know a form to capture refusal of blood products has been developed with an imminent release. So, Penny, given that many groups are invested in these forms for various reasons, what were the guiding consent principles in designing the form?
Yeah, thanks, Ellie. Look, there was probably five guiding principles that we used in the development of this form. The main thing that guided this work is that refusal is an aspect of the consent process. Patients can and do at times refuse treatment, and in this case, we just happen to be talking about blood and blood products. Remembering that refusing blood products usually happens in the context of consenting to a different procedure, e.g., you consent to surgery but not to blood products. And that's where it becomes a little trickier. So in New South Wales, we're fortunate that we have a comprehensive consent to medical treatment manual for New South Wales health hospitals. And we know that that supports staff and patients in the consent process. And it includes lots of information about patients refusing treatment. So anything that the working group developed had to align with the requirements of the consent manual. And as I said, it's extensively explained in the consent manual. I suppose one of the key points I just need to highlight is that this is not a separate transfusion consent form. And as we'll see when we look at the form, it must only be used when there's an element of refusal of blood products. So that's the first thing.
Mm-hmm.
I think the second thing that we just need to keep in mind that we shouldn't assume that we know why patients may indicate that they don't want to accept some or all blood products. I think historically we've probably thought we might know why that is, but increasingly that's changing. It becomes especially important when you're considering the range of blood and blood products and the associated procedures that a doctor may recommend for someone. And in the experience of the working group, I don't think there was anyone who had managed someone who had refused all blood products and associated procedures. So we had to keep that in mind, and that we needed the finished product of this group would need to be meaningful and useless, regardless of why the person was indicating that they refused blood and blood products. The third point that we really had, that we kept at the forefront, was that the form had to be specific enough that a person's wishes could be easily communicated across healthcare teams. And this is particularly important for doctors who may never have met the person, for an example, an anaesthetist who, might not meet the person until the day of surgery. I think the next thing that we had to consider is that we shouldn't assume that people won't change their mind, regardless of any decisions that they've made in the past. And this is where it's important to keep coming back to the principles of consent. Just because somebody made a choice 5 years ago doesn't mean that they would make that same decision today. And I think the last thing to just bear in mind too was that this form is not a clinical guideline. We, of course, know that where patients decline blood products, that the early identification and documentation of acceptable and unacceptable blood products and treatments is vital. And this ensures that we can have a comprehensive multidisciplinary plan and approach. But there's plenty of information to support this available, and you can find that in the New South Wales Health Blood Management Policy and our patient blood management guidelines that are used across Australia. So there's lots of information about that. This form was not trying to replicate that. But bear in mind, once someone does decline, that is certainly a clinical consideration.
Mm.
So that were the main points, Ellie.
Mm-hmm. Thank you. So we've heard that these conversations should be based on existing capacity and ACD principles. Mel, this one's for you. Can you tell us more about this from your experience?
Yeah, sure. Well, capacity means a person has the ability to consent or refuse medical treatment. And sometimes a person loses capacity because they are no longer conscious or competent to make their own informed decisions. It's really important to try and document what a person will or won't consent to while they still have capacity. Some people put their wishes in an advanced care directive, which can be really helpful. This is a legal document that may contain specific directions about their limitations or refusal of healthcare treatments or interventions, and sometimes this includes transfusion of blood products. It must be made voluntarily while the person still has capacity, and it also needs to be clear and intended to apply to the situation at hand so that the healthcare providers can follow it when the person can no longer tell them what they want. An ACD is intended for future use only when there are no opportunities to have that shared decision-making conversation about the situation at hand. When a person loses capacity, any directions in an ACD must be respected no matter what the reasons behind them, if there hasn't been that shared decision-making conversation while they still had capacity. If the patient still has capacity and their ACD is not valid, or in the case of refusal of blood products, it might not clearly articulate which blood products they will or will not accept, or any related procedures. They should be recommended to update their ACD as soon as possible so that it can be followed in future. But if a person has capacity, a shared decision-making conversation between them and their multidisciplinary team is required, regardless of whether a valid ACD is in place, to ensure that decisions are clear and specific to the treatment or procedure being proposed at that time. These decisions must be clearly documented in the healthcare record so they can be clearly communicated to the team. So the new New South Wales Health Refusal of Blood and Blood Products form can facilitate that conversation and enable clear documentation of the informed consent process regarding any element of refusal of blood or blood products.
Thanks, Mel. So Penny, this one's for you. This is the last question. So Penny, how does the new form and consumer information support this process?
Yeah, thanks, Ellie. Look, I might just ask Mel to take the first half of this question, if you don't mind, Ellie, and I'll hand over to you, Mel.
Yeah, sure. Well, it's a 4-page bundle containing plain language consumer information which accompanies a form to formally document refusal of blood and blood products. The bundle supports clinicians to have that respectful, structured consent conversation by stepping through all the blood products and procedures that could be available to them. The consumer information about the products and procedures guides the clinician and the patient through that shared decision-making conversation. And then the form ensures the decisions are clear and there's no confusion within the multidisciplinary team as to the patient's choices of what they do and don't consent to.
Yeah. Thanks, Mel. And just picking up on that, so just like a consent form, this form only relates to the treatment of the disease, condition, or the operation specified on the form. For example, this could be elective surgery, it could be for a pregnancy, or as part of a course of treatment for cancer. So I suppose the main thing, if in doubt, keep returning to the principles of consent. The reason that this is not an enduring document like an advanced care directive is that new treatment options can become available. So there's a responsibility to provide all the available information to a person that might inform their decision. Remembering that the implications of their decisions may change over time. So the implications for refusing blood for a simple procedure compared to a life-threatening one, they may come to a different conclusion and consent to something different. So it's not a case of a one-time decision. It really is a decision that has to be a conversation that we keep having to have with the patients and just ensuring that their choices are valid every time.